Hello, my name's Dr. Robert Fawcett, and the program we have for you today is called Calming the Bipolar Storm, Part 2, Treatment of Mania and Depression. Perhaps you saw our first episode on public educational TV or on the YouTube. It was just called Calming the Bipolar Storm. But today we'll be primarily talking about the treatment of mania and depression. And what are some of my credentials? Well, I did my psychiatry residency at the University of Michigan after getting my MD at Wayne State University School of Medicine in Detroit. And I'm board certified in general psychiatry. I've been a past medical director at the inpatient unit in Petoskey at what was called Northern Michigan Hospital. Now it's called McLaren Hospital, Northern Michigan. And I was a past assistant clinical professor at Michigan State University, taking part in teaching medical students who rotated through our unit. I've been a past psychiatric consultant at North Country Community Mental Health and Northern Lakes Community Mental Health, and have seen lots of persons with bipolar mood disorder in those settings, and also had an outpatient psychiatric practice for 38 years and saw plenty of people with bipolar mood disorder there. In fact, sometimes I would see families actually treating 3 generations of persons with bipolar mood disorder. So the fact that I've been in one place kind of gives me a unique perspective in having seen some people for many, many years over time dealing with their bipolar disorder. And I've had scientific publications in some of the journals listed there and a few others, and written a book called Calming the Bipolar Storm. Now, in the treatment of bipolar disorder, a person might come in contact with a variety of health professionals. Psychiatrists like myself have MD or DO degrees, and then usually do a year of an internship and 3 more years of psychiatry residency, or sometimes now they're kind of combined into a 4-year program. Psychologists who may have master's degrees 1 or 2 years after college graduation, or they may have a PhD or a doctor of psychology degree where they have to spend probably 4 years or more after college graduation. They're often involved with psychotherapies and testing and assessment of persons with bipolar disorder. Social workers, some have bachelor's degrees, some master's degrees, and they're often very skilled at psychotherapy, individually and marital and family therapies. Sometimes counselors of various kinds might be involved with treating people with bipolar disorder. Substance abuse counselors, for example, come to mind. Primary care physicians, like family practice doctors, may get involved, especially in prescribing medicines for people with bipolar disorder. And sometimes maybe pediatricians for youngsters with bipolar disorder, or internal medicine doctors or neurologists. And there are a lot more nurse practitioners today. Nurse practitioners, many of them will specialize in mental health, where they do an additional year of academic training and then a year of internship where they're treating patients supervised by a psychiatrist. And physician assistants as well may specialize in mental health. Certainly it's important to have a good relationship with one's treating providers. Some studies even find that the rapport or the good relationship with a treating provider may be more important than the specific medicines that are prescribed or the specific form of psychotherapy that a therapist might use with a person with bipolar disorder. So having a good relationship is very important. Some people might have to try a few doctors or therapists out to really feel like they have a great fit. Well, let's turn to talking about the treatment of acute mania or hypomania. That's the phase of bipolar disorder when people are often agitated and not sleeping. They may be talking and moving rapidly. Sometimes they may have hallucinations like hearing voices or delusional, grandiose thoughts even. So many times they may be treated in a hospital setting. Sometimes it can be treated as an outpatient. Those that have the milder hypomania are usually treated as an outpatient. And two types of medications are very prominent in that treatment. Mood stabilizers like lithium or Depakote, which is valproate, Tegretol, which is carbamazepine, or Trileptal, which is oxcarbazepine, are all kind of classed as mood stabilizers. And lithium is a very significant drug. An Australian psychiatrist, Dr. John Cade, did a study back in 1949 where he used lithium on 10 hospitalized patients in Australia and published that. And that was really the beginning of the modern era of psychopharmacology. All 10 of the patients he treated with lithium improved. One gentleman even had been in the hospital continuously for 5 years, and he was able to go home. Mood stabilizers take a little while to work. Usually it takes 5 days, give or take, for the medicine to kind of reach a therapeutic level. And then probably another week for a good therapeutic effect to start kicking in. And maybe, a total of 3 weeks or 4 weeks to really get a good handle on trying to reduce the abnormal mood back to normal. The second generation antipsychotics, the other group, works much more rapidly. And that includes aripiprazole, which is Abilify, and risperidone, which is Risperdal, olanzapine, which is Zyprexa, and quite a few of the others there that I have listed. And they often may have some beneficial effects within hours and certainly within days. And part of the game in treating acute mania and other parts of bipolar disorder is trying to minimize side effects. You may have a number of medicines to choose from which can be very helpful, but you're also trying to minimize the side effects so that people can tolerate the medicine and stay on it, because bipolar disorder is an ongoing disorder that needs treatment. So side effects with lithium can include tremor and gastrointestinal side effects like heartburn and diarrhea, weight gain, sometimes sleepiness. A very small percentage of people can develop hypothyroidism or a low thyroid condition. Usually people have increased thirst and increased urination on lithium. And the same with valproate or Depakote. There's tremor and gastrointestinal side effects, weight gain, and sedation can be a side effect also. And just the term mood stabilizer itself is a little bit vague. We can define it as meaning a drug that helps in one phase of bipolar disorder, either mania, depression, or the maintenance phase, and doesn't really cause harm or disrupt mood in any of those phases. So, for example, lithium can help calm a manic phase and can help improve depression and can help prevent relapse. And to some extent, so can Depakote and Tegretol or carbamazepine and oxcarbazepine. Carbamazepine or Tegretol is an FDA-approved treatment for acute mania, and it can have some side effects. Occasionally, you can see a real severe skin rash. Sometimes there can be a low sodium. Sometimes there might be some sedation or a feeling of mental dulling. And it does have a lot of effects on other drugs, which sometimes makes it not the first choice. As an example, birth control pills, starting on the Tegretol, often will lower the level in the blood of a birth control pill, sometimes low enough that the birth control pill won't be working to prevent contraception. So sometimes you have to adjust the levels of other drugs if you're using Tegretol. And it can have effects on white blood cells, red blood cells, and platelets, and sometimes cause elevation of liver enzymes. So those are all things that get monitored. The oxcarbazepine or Trileptal is not really FDA approved as a treatment for bipolar disorder in this country. It is an approved drug in many European countries, and it's approved for the treatment of forms of epilepsy in this country. And it tends to have, somewhat fewer of the side effects and the complications with affecting other drugs' metabolism, much less so than the Tegretol. So sometimes it is used in treatment of bipolar mood disorder. Now, the antipsychotics, which I referred to before, and there's lots of those that are approved for treating mania, often reduce the agitation aspects within a matter of hours. Sometimes they might be given IM or orally or as a liquid, and they work rapidly, and they often reduce symptoms like hallucinations or delusions, sometimes in hours or often in days. And they're called second generation antipsychotics because they have, or atypical antipsychotics sometimes, because they have fewer of the neurologic side effects that the first generation of antipsychotics did. The first generation were medicines like Thorazine or chlorpromazine or Haldol, haloperidol, and the second generation antipsychotics tend to have much fewer of these neurologic side effects. What are these neurologic side effects I'm referring to? Well, one, acute dystonia. Dystonia really means an abnormal tonicity of muscle contraction. So, for example, somebody given a shot of haloperidol might develop a side effect where their neck twists to the side involuntarily, almost like a severe wry neck. Or another possibility is having the eyes roll upward in your sockets so that you can't bring your gaze downward. And those can be very distressing and kind of frightening side effects. We usually can rapidly reverse those with another medication, but it may make somebody reluctant to take those medicines again in the future. And they usually occur very shortly, within hours to days of starting one of the antipsychotics. Pseudo-Parkinsonism really means a condition that simulates Parkinson's disease. And we can see this in a matter of usually quite a few days, more often maybe a few weeks or even a few months after starting an antipsychotic. So people will get the pill-rolling tremor of Parkinson's disease, muscle stiffness, poor balance. Often their face will show less expression. They'll have a reduced blink rate. They may have trouble getting up and down out of a chair. All those things that we see in Parkinson's disease. And those side effects too can be treated with a type of anti-Parkinson medicine, or sometimes reducing the dose or switching the dose may take those away. Acaphesia is a side effect that's experienced as restlessness, often restlessness in the legs, sometimes other parts of the body. What you view from looking at a person with acaphesia, often they're bouncing and jiggling their leg, or they feel a need to get up and pace around. And there are treatments that can reduce that acaphesia as well. Tardive dyskinesia, perhaps you've even seen some TV commercials about some treatments for tardive dyskinesia. The tardive means, think about getting to school, you're tardy, you're late. It's a late onset kind of side effect, often not showing up for 2-3 months or more in someone taking one of these antipsychotic medicines. And the dyskinesia means an abnormal movement. Very frequently we see abnormal movements of the face, grimacing, or funny movements of the mouth or tongue. Sometimes there can be wiggly movements of the fingers, or what might be called choreiform, which means dance-like movements of the limbs, or athetoid, which means worm-like movements in the limbs. So there can be a variety of these involuntary movements. And so we try our best to prevent those things, certainly. And now there are some other medicines out. Valbenazine and deutetrabenazine are two that treat tardive dyskinesia. And the neuroleptic malignant syndrome is a very uncommon kind of neurologic side effect. Usually 1% or less of people that might be hospitalized with acute psychosis and treated with antipsychotic drugs. And neuroleptic malignant syndrome is a medical emergency. People might develop high blood pressure and even an abnormally elevated temperature and excessive muscle stiffness, and they usually need to be treated in an intensive care unit for that problem. Now, we talked about the tardive dyskinesia with the late onset of these abnormal movements, and the first generation antipsychotics, it was estimated that if someone took them continuously for a year, there might be as many as 5 or even up to 8% of people that would develop some of this tardive dyskinesia in a year's time. With the second generation antipsychotics, it's much less, like 0.8 to 2.9% a year. So that's been a big plus to try to, minimize and prevent the development of that side effect. And certain risk factors make a person more susceptible to developing tardive dyskinesia. Older age is one, being of female gender is another, being of an Afro-American background. Non-schizophrenic, such as bipolar persons, might have a higher risk for tardive dyskinesia than persons with schizophrenia per se. Diabetes mellitus is another risk factor. And if people are taking lithium or an anti-Parkinson drug along with the antipsychotic, that's another risk factor. And it does seem as though people that maybe develop some of these early side effects, like they mentioned the dystonias or the Pseudo-Parkinsonism early on in treatment, are at higher risk for developing tardive dyskinesia months or years down the road if they continue on an antipsychotic. Well, now I'm going to talk about some other kinds of side effects of these second-generation antipsychotics, because again, as I say, part of the name of the game is trying to successfully treat people with a minimum of side effects if we can. And that's a tendency for weight gain. Clozapine and olanzapine, that's Clozaril and Zyprexa, are two of the worst offenders for weight gain. Quetiapine or Seroquel and risperidone or Risperdal are kind of intermediate. And Geodon or Ziprasidone and Abilify or aripiprazole have the least tendency for weight gain. Many of the second-generation antipsychotics have some tendency for weight gain, but some of these other ones, Lorazepam or Latuda, Asenapine or Safras, Iloperidone or Fanapt, Cariprazine or Vraylar, Brexpiprazole or Rexulti, they all have less tendency for weight gain than olanzapine or Zyprexa. And I'd add another, the other newly released lumateperone also has much less tendency for weight gain than olanzapine. And why do we worry about weight gain? Well, certainly nobody usually wants to gain an extra 10 pounds. They may not like the way it looks, and they may worry about growing out of their clothes, but it also has a lot of medical implications. There's what we call the Metabolic Syndrome that includes obesity and high blood pressure, diabetes, and hyperlipidemia. So gaining weight, crossing the line into obesity, often can increase one's blood pressure. And it's a risk factor for diabetes mellitus type 2, and also for hyperlipidemia, that is the elevation of cholesterol and or triglycerides in the blood. And we often get a good sense of whether a drug is going to cause weight gain after a couple weeks, weighing the patient before they start and again in 2 weeks. If they've gained a couple pounds, that is predictive that they're very likely to keep gaining weight as they stay on that drug. And sometimes that may be a clue that we want to change to a different medicine that's less prone to weight gain, like one of those we mentioned, the aripiprazole or ziprasidone or some others. And besides the risks of the weight gain, and let me say this, that with weight gain, it's always a balance. You only gain weight when you take in more calories than you burn. So many times by reducing your calorie intake or increasing your exercise, you may be able to prevent gaining weight when you go on one of these medicines. Another potential side effect is prolactin elevation. And prolactin is a hormone that comes into play when women are pregnant and give birth and start nursing. Prolactin is secreted from the pituitary gland up in our base of our brain, and it increases breast tissue, and it helps in the development of milk. And so we can see some of that as a side effect of some antipsychotic drugs, where we see an increase in breast tissue. Some people notice actually a soreness in their breast, and sometimes there can be a milky discharge from the breast, and this can occur in both women and men. I've only seen it in risperidone and Invega or iloperidone among the second-generation antipsychotics. The others, it must be extremely rare if it occurs there. And it does occur in first-generation antipsychotics like Haldol and Stelazine and Trilofan. And so if that happens, often we look at changing to a different medicine, or I think it is possible sometimes that adding Abilify might actually block some of that effect. And other miscellaneous side effects of the second-generation antipsychotics. Hypotension means low blood pressure, and sometimes we see what's called orthostatic hypotension. When somebody goes from sitting to standing, their blood pressure drops too much and they get dizzy, or they might be prone to even falling or passing out. So that can be a potential side effect. Sleepiness can be a side effect. Uncommon side effect is seizures, but that can rarely occur, or impaired swallowing. Impaired temperature regulation could occur. We most often see that probably in the summertime, where somebody isn't sweating as much as they should, or their peripheral vessels aren't dilating the way they should, and so their body temperature actually goes up. They might have a fever. And again, that's an uncommon one, but can occur. And just kind of poor coordination and increased suicidality is a kind of a group warning that the FDA adds in there, because many of the second-generation antipsychotics can be used as antidepressants. And some antidepressants have shown an increase in suicidal thinking, and that's primarily in adolescents and young adults up to the age of 24, actually. And then there's anticholinergic side effects: dry mouth, constipation, difficulty urinating, blurry vision, increased heart rate, and in the elderly, confusion. This could happen with some second-generation antipsychotics. It's a not uncommon problem with many drugs used in medicine. Many drugs used in gastrointestinal diseases and urinary diseases and cardiology can have these anticholinergic side effects too. So it's also important to watch out about drug-drug interactions if you're taking other drugs that have some of these anticholinergic effects. Well, besides we've talked about the mood stabilizers like lithium and Depakote, and the second-generation antipsychotics like Abilify and Risperdal. And other medicines can be used acutely in treating mania. For example, benzodiazepines like Ativan, which is lorazepam, or Valium, which is diazepam, might be used to reduce agitation or anxiety. The Z drugs like Zolpidem or Ambien might be used to help sleep, and getting a good night's sleep can help significantly in dampening manic symptoms and bringing people back to a more neutral ground. So many times they might be used acutely when someone is manic. Calcium channel blockers are occasionally used in mania. Allopurinol is a drug that lowers uric acid in the blood. It's used in gout, for example. And there are a number of studies showing that it can have an anti-manic effect. And I've used it myself with a few patients who weren't able to, for various reasons, tolerate many of the more traditional drugs. And finally, electroconvulsive therapy. We usually think about that as a treatment for severe depression, but it also can help to cause remission from an acute manic episode. And it might come into play, for example, if you had a woman who was pregnant and acutely manic. Using ECT would prevent the fetus from getting exposed to a lot of medications like, say, lithium or second-generation antipsychotics. So a decision might be made that all things considered for mother and baby, that might be the best treatment. So now we'll turn to the treatment of bipolar depression. A couple of facts there. Folks with the bipolar 1, which is, having full-blown manic episodes and depression, they spend about 3 times more days depressed than they do manic. And folks with bipolar 2, that is where they have hypomania and depression, will spend about 39 times more days depressed than hypomanic on average. So we can see that the depression, time-wise, takes up a lot more of a person's days than the manic side for most people with bipolar disorder. And we've got quite a few FDA-approved treatments for mania that all may work reasonably well. We only really have 5 drugs FDA approved for bipolar depression. And whereas we can see a rapid response with second-generation antipsychotics, for example, much improvement in the matter of sometimes hours to a day or two, the treatment of depression with the traditional agents in depression is much slower. It takes place usually over, you're talking about weeks' time, maybe a couple weeks